morning, everybody. Welcome to our weekly medical grand rounds. Today, I am delighted that we're going to cover a very important topic in this time. We did have a little bit of discussion about this topic when we were doing our COVID rounds, but I don't think we gave it enough attention, and we've heard again and again that this is something that's a challenge, which is teaching learners in the virtual environment. So I'm delighted to welcome our panel, who's going to educate us on how to do this effectively. So today we have Dr. Jonathan Choi, who is the Associate Dean for Clinical Faculty in the Faculty of Medicine and Dentistry. Dr. Sudha Copula, who is the Director of Faculty Development for the Department of Family Medicine. We have our own Dr. Anna Oswald, who is the Director for CBME Implementation for the Faculty of Medicine and Dentistry and a rheumatologist in our department. And we have Dr. Lynn Sonnenberg, who is the Associate Dean for Educational Innovation and Academic Technologies. So without further ado, I'll hand it over to Jonathan. Thank you.
Good morning, everyone. I just want to disclose that I also have another role with AHS, and some of the information I'm covering actually will be AHS material, and those are the other disclosures, just to state our roles. Thanks very much, Norman, for that introduction. In the interest of time, we're going to fly through this quickly and then open it up for discussions. And I think these are our objectives, and I think that it's important for us to consider when we're practicing virtual medicine or virtual care, what some of the standards and recommendations are, how to protect yourself, your learner, and your patient. And then my other colleagues are going to share with you some of the best practices for supervision of learners, how to incorporate competency-based assessment in feedback into the virtual environment, and some of the nuances of how to use Zoom, not only just to conduct a simple visit, but also using breakout rooms in big multidisciplinary clinics, some practical tips on that. So general considerations for providing virtual care is what I'm covering. And, care delivery, no doubt, has changed. When we had a state of emergency, all of a sudden, 50% of our clinic visits, over 50% actually, when we look at Connect Care Wave 1 data, outpatient visits went down. But increasingly, though, there is a move towards patients' expectations, saying, well, why couldn't I? And you've heard this for years, right? Why can't I just connect with a doctor over the phone for a prescription renewal? Why must I come in to see the doctor? And of course, there are many reasons for that, including compensation, but that's not what we're here to cover today. But now that the goalposts have changed, the expectations forever, I think, will be different for our patients. The first thing and the most important thing really is to remind all of us, respect the virtual spaces with your physical clinic. And just as I was thinking about starting, something came to mind. A few years ago, I had a resident, a fellow actually, send a text message, was intended for one of his friends. And as you know, those people that use the iPhone, occasionally it ends up texting the wrong person. And in the text body, it said something like, I don't know why JC is complaining of how busy he is. He's been in meetings all day and now he's got 30 echoes to read and he says it's too busy. So the message wasn't intended for me, but accidentally sent to me. And these are some of the dangers of quote unquote virtual care. So we can see here a really sweet note that Anna wrote to her kids saying that she's giving a talk till 4 p.m. Please keep quiet. So in other words, don't forget that even if you're in a virtual space, even if you're at home, respect that space. So bear in mind, where are you? Make sure you have the door closed. If at all possible, it's more professional to not hear the dog barking, and various other things that we'll cover quickly. But here's some of the considerations that I want to go through quickly. So before the visit, how to introduce that topic to your patient, identifying your patient and consenting, even though you and I both know that we recognize our patients' voices, and when we phone them, we rarely do this. But when we're providing consultative care or follow-up care, as opposed to a quick follow-up phone call, all of a sudden the game changes a little bit. We want to make sure we identify who's on the call. not only on our side, but the patient side. First week or two when I was doing this virtually, I forgot to ask, is anybody else listening on this phone call? And if we have a learner, it's important to say, okay, we have a learner, his or her name is whatever, and are you okay with that? Setting the stage and the expectations is also very important. And then to decide whether or not you want video, telephone, or secure messaging. Video is okay, but sometimes it's complicated, and it's complicated for the patient to set up. The good old telephone, we've been using it for 20 years and never thought of it as quote unquote virtual care, but we're doing a lot of that. And finally, document, and we'll end by providing you with some resources on delivery of care. So please consider having your medical office assistant confirm the best phone number to use. Otherwise, you may be dialing 4 different phone numbers before you finally get a hold of the patient. Both ends, they should be checking for a good internet connection, because if you're going to use video, it needs a lot of bandwidth. Warn patients of data consumption. It's around 600 megabytes, 600 to 650 megabytes of data per hour of video conferencing. So if you don't have a good data plan, you're going to chew that up in 3 or 4 clinic visits. And if there's learners in your clinic, and the patient should be able to consent or refuse a learner. And also, this is a very important point. You may call early or late, but have the patient stay available, because I have had instances where the patient calls in, or I call into the patient 15 minutes early, they're not expecting me and they're doing something, or I'm 15 minutes late or 5 minutes late running behind, and they've gone out or they've turned their phone off thinking that I'm not going to call. So they need to be educated that a virtual clinic is like a real clinic room. Sometimes you have to wait. So obviously verifying the patient with 2, this is the AHS recommendation, 2 particulars like a birthday and a ULI or healthcare number. There's a consent script that is on the website for AHS. But basically, you just want to cover why we're doing this virtually and not in person, and advise the patient that the visit can be terminated at the patient's request. And also, I guess, the learner can be removed at the patient's request. Introduce who the people are if you're doing a multidisciplinary team. And this is just standard practice. We do that in real person, and we need to do that virtually, and make sure we introduce the learner. Both from the patient and provider perspective, are we in a private location free from distractions and interruptions? And we've already talked about, is anybody else in the call? It's important for you to know who else has access to the medical record. Strongly discourage virtual backgrounds. As an example, I was on a call yesterday where the person I was on with, and this wasn't a patient, just a conference call, he just put his chair back, and then all of a sudden, he disappeared from the screen. We do not want to do that, because it otherwise, it's like working with a one-way glass. Patients can't see who's there. You can't see in the patient's room who is there. So we actually recommend turning off virtual backgrounds, just so that everybody is transparent. And private chats turned off when I do it, because if you're in a group setting and you're doing group therapy or whatever it may be, having patients privately chat each other is probably not a good idea. Secure messaging, video, or telephone. This is something that you need to consider. Certain secure messages may not be saved in the medical record. Definitely physician to physician secure messages, there's a disclaimer saying it's not saved, but make sure you document whatever's said. And question, is video mandatory, to avoid sort of the necessary complications of not being able to connect properly. These are the 8 things that the CMPA asks you to pay attention to. There's the link right there for you to go to the CMPA, but basically ensure, privacy. And the Zoom thing, if you're going to use it within AHS, Connect Care, or outside of it, using the AHS platform, privacy has been ascertained. We want to make sure that there is explicit consent in whatever way, shape, or form, and that it's documented in the chart. And just make sure that if you're only doing videos or images, make sure that the patient taking the images, if they're going to do that and uploading them, it's secure. The most important thing is document, and everybody knows that. So recording by patients, just be aware that patients do not require our consent to record the encounter. They cannot directly record on Zoom, but you never know if they're recording your phone call, if they're recording your video using screen capture. If they explicitly ask you, just clarify, why would you like to record this and what are you hoping to achieve with it? And see if there is an alternative to it. You can choose to accept or decline the request. If you decline it, you know, please explain to your patient, I guess, why you're declining it. And if the patient insists on recording, you need to decide, are you comfortable with it? Or are you going to terminate the appointment? And make sure that if the patient is recording, you know, note this in the medical record and ask for a copy of the recording to be maintained, which is challenging because at the moment we haven't figured out in Connect Care how to store recordings. Asking these questions are important. Why is it necessary? Oh, this is for you to record. Why do you need to record? Make sure patient consents, and do not store your images on video or video on personal devices. If at all possible, use secure portals like Haiku Media Capture to capture still images. And there's a function there that you can upload into the patient's chart directly. So that kind of concludes my section, and I'm going to hand it over to Asuda to talk to us about teaching and the general principles of teaching in virtual care settings.
Well, thanks very much, Jonathan. I'm just going to share my screen now and continue on from where you've introduced us. So good morning, everybody, and it's a pleasure to speak to you. I wish I could see all of your faces this morning. I'm sure we have a great audience, and I appreciate all of your collaboration, either clinically or academically. I do appreciate it. My name's Suda Copula. I might know some of you. And hope I have. I'm a family doctor at MacEwan University Health Center, and at the Department of Family Medicine, I'm the Associate Chair and the Director of Faculty Development. So I've been asked, and the four of us presenting today decided that what might be useful is for me to provide a handful of principles with respect to teaching in virtual care settings. So that's why you see a hand. We also figured the hand does a couple of other things. When I see a hand like that, I think to stop and pay attention, which is what we are hoping that we do when we are teaching in virtual care settings, that there's a deliberate sort of set of steps or process. And also a hand reminds me always to wash my hands, very timely these days. So here's number one of the general principles. The first thing to keep in mind is that teaching in virtual care settings is new to us just the same way as it is new to learners also. This is an opportunity I find to promote lifelong learning principles with our learners, and to just make it really explicit that, you know, even when we're done our formal education and we're out in practice, things happen, like pandemics, for example, and we have to learn to adapt. And lifelong learning principles are really key in ensuring that we have those skills and abilities to adapt to new things. So having an explicit conversation to say that, you know, I've done my formal education, I know I'm precepting you today or over the period of, you know, a longer period of time, but I still pick up things. This is new to me, it's new to you, and let's learn together. So I wanted to introduce to you a guide, and this is where I'm getting many of the general principles, and it was developed by the CFPC, so the College of Family Physicians of Canada, but it is applicable far more broadly than just the Family Physicians of Canada. So what it is it's a guide for tips for providing supervision for learners who are providing virtual care. And so myself and my lovely co-presenters, we all had a look at it and said, you know, isn't this applicable far more broadly than family medicine? And we decided, yes, it was. And we'd like you to have a look at it too and look very closely and see if it does apply to your context as well. We know that all of you provide education to our family medicine learners, and we greatly, greatly appreciate it. And as well, we hope that this provides some direction or some guidance when you're teaching learners from other disciplines also. So here's the tips. There's number one, asking about the learner's experience with virtual care and their understanding of its conditions or limitations. For example, it's not the same as social media if you're providing virtual care with video, for example. Number two, determine the level of supervision needed. Some of our learners might have had different experiences or more extensive experiences with providing virtual care. Number three, consider the supervision approach. There's many different ways that that can be done. For example, you can yourself, your learner, your patient might all be connected virtually. Number four, ensure the learner obtains patient consent to providing virtual care, and that's very important, and that's a key part of providing virtual care. Number five, review the patient presentation, paying attention to key considerations in virtual care. In particular, keep in mind that some examination might be possible, but we want to be really clear of what kind of examination may be possible. 6, reviewing the learner's documentation of the visit. And 7, consider providing formative documentation for assessment purposes. So you can click on that link that's at the top of this slide. You can pull up the guide. We didn't provide it to you just because it is very hard to read on a slide, but the tips are summarized just like I've gone over. But you can click on that link and see how it all applies to you. And we think it really would. So quick 5, who, what, when, where, and why of this guide. It was developed by the CFPC, and it is a guide for supervising learners providing virtual care. That applies to, just like Jonathan said, video platforms, but also phone platforms as well. So this began at the beginning of this pandemic, but what was interesting is that so many family medicine electronic medical records actually had video platform capabilities prior to the pandemic. We just hadn't used them, but we are now, because of this need, going ahead and using this kind of technology. So we developed this slide at the CFPC virtually. Those of us who helped to develop it did so on a virtual platform. It's applicable virtually. And why? Again, the need was there. Where we know that the Royal College as well as the CFPC are very responsive to teachers, and the CFPC ended up putting this guide together, and we're hoping that it is applicable more broadly, for example, to Royal College teachers also. So here's principle number 3. We were on those 5 points in the handful of general principles. This is number 3. Asking about the learner's experience with virtual care and the understanding of its conditions and limitations. And I mentioned that a little bit when we went over the tips from the guide. Number 4 is considering the supervision approach. Sorry, that's number 3, considering the supervision approach. And then 4, reviewing the patient presentation, paying attention to key considerations in virtual visits. So like I briefly mentioned, one of those is that some examination might be possible. Some demonstration also might be possible. When we first provided this talk, there was one of our participants in a small group that actually said, you know, you can actually take like a model, for example. In my practice, for example, I do a fair amount of women's health. I have taken an IUD model, for example, and demonstrated it to a patient. There are some limitations, of course, with physical exam. We want to make sure no sensitive exams are done in a virtual sort of platform, and making those things clear to learners when we are providing virtual care in these settings. Here's our number 5. Here's our last general principle of the handful. Do what you know. I know you all as really strong teachers and very valued to our family medicine learners. We know that you're experienced clinicians and clinical teachers. You already have the principles, many of the principles down. One of the things is the patient-learner interaction. In some ways, virtual care settings provide opportunities for direct observation that we don't typically have. So you might be able to observe and provide feedback on histories, for example, as compared to something later in the clinical encounter. Again, some physical exam might be possible. Reviewing with a learner is always important, and doing so, promoting critical thinking, and then providing feedback. And there's a guide for that too. I have a link for you, in fact, and I'll give that to you in just a second. So again, here's our summary of our general principles. This is new to us too. Second is that exploring the learner experience is important, so you know where to start. Third is deciding on how you're going to supervise them. 4 is reviewing the patient presentation, considering that some physical exam may be possible, some might not be. And 5, do what you know. So here's a couple of resources that I mentioned. So the first one is the guide itself for learners providing virtual care. And the second is about writing feedback for learners who are providing care in virtual care settings. So with that, I just want to thank my co-presenters for the invitation to come here to speak today. I think it's a real strength that at our faculty, we're able to have family physicians, consultants, Royal College, CFPC, all help each other. I think that's really valuable, and I've learned a lot from my co-presenters. Andrea, thanks so much for your help with pulling us all together. And again, I want to thank all of you for your continued teaching efforts. So with that, I will stop my share and we'll go on to Anna.
Okay. Thank you, Sudha. I hope you can all see my slides now. Sudha and Jonathan have set us up in terms of privacy and expectations and principles, and I'm going to go into the nuts and bolts and nitty gritty. And for those of you who were part of the June rounds, there is some overlap here, but I apologize if you've heard my stories already. I have updated the section. Okay, so to me, patient safety, learner safety need to be top of mind. And so learner safety involves protecting the learner's privacy. So teaching learners how to block their outgoing numbers. A quick Google search will help you identify that because every phone is a little bit different. And making sure that if the patient, expects that a blocked caller number will come, I have mine let all the patients know. Despite that, patients will forget, or they may have it set as a default. They don't know how to undo blocking a blocked caller number. And if that's the case, you need a workaround. So the learner can use the switchboard to connect that call for them, and then it will only show the switchboard's caller ID. Keep in mind though, if it's a long distance call, you need to give the learner your long distance code because otherwise switchboard won't connect. And I think this is overlooked often. I think sometimes we forget about learner safety, and I want to share a story that when I was a resident, there was a colleague of mine who had an incident where a patient got their phone number, and this subsequently resulted in increasing stalking. The patient would call them and text them at all times, demanding responses at very frequent intervals, to the point that the CMPA had to be involved. The CMPA had to send a cease and desist letter to the patient. This was extremely troubling to that resident. It was very stressful for them. And so I think we don't know what else is going on in our patients' lives, and we really need to protect our learners in that way and their privacy. The next thing I would say is obviously patient safety. Even though it's virtual, you still need to supervise the learner. It's not okay to say, well, it's virtual, I just let them go ahead and they called me at the end of the day, unless that's your normal practice for that setting. You need to have a backup number for that patient. There's nothing like a patient having a crisis in front of you on a video screen and you can't get a hold of them. I've had a few patients who've stood on swivel chairs to try and show me their knees or feet. Each time it gives me like a sinking feeling in my stomach. Please go down. Please don't fall off that swivel chair as you're trying to show me. It's not worth it. So I would not want to see a patient fall and then not be able to seek help for them. Jonathan has already covered the consent process. I use a Connect Care smart phrase and I share it with my learners so that, and I'm quite directive in terms of, I want you to say these words. and go over it. Sometimes I listen in if it's a new learner to me. If it's a learner that I've worked with extensively, then I may not. And then secure communication. And this is tricky because right now we still require signed prescriptions. And I'm hopeful that that will evolve, but the current state is the prescriptions that are produced, particularly if you have senior learners who are expected to provide the prescriptions, need to be signed. And then they need to have a way to transfer these documents. And so reminding learners that AHS email is appropriate, Haiku uploads are appropriate, but their own UL Alberta email is not appropriate, and that they need to ensure that they don't have copies left on their devices. And so the awesome thing about Haiku, which is available for mobile devices, is that you can take a photo of the prescription and upload it to media for your admin to then fax or to the pharmacy or send to the patient or whatever your workflow is. And I think keeping in mind, some issues are just not amenable to virtual care. And I think that's okay, you know, and deciding how you're going to deal with that. We now do have access to some ambulatory outpatient appointments. So looking at that. So it is best to just be honest about where you're at with your learning and do this as co-learning. As Sudha said, we're all learning. This is new to all of us. But you do need to do a little bit of diagnosis as you would do with a learner in person to figure out where they're at when you start working with them. And so what is their familiarity with virtual technology? For the most part, I find learners have more familiarity than me with virtual technology, and they have taught me some fantastic, you know, little hacks and workarounds and ways to approach this. But I also have encountered learners who, despite their, you know, belonging to whichever generation, are not okay with virtual learning, have not really become familiar with the features of different platforms or tried it before, or maybe have avoided it. And so just being clear about what your expectations are is really important. With phone, I find it really helpful for three-way calling. Again, this is something you can do a Google search. Our office phones in clinical sciences do have the ability for three-way calling. My admin wrote out a little step-by-step for me, and it sits by my phone so I can remember how to do it because I didn't used to do that before. Your mobile phone will typically have an add call, merge call feature, and you can do a Google search to figure out how that works. And that's great because you can just sit and listen as the learner is, for example, counseling a patient or taking a history or whatever it might be. And then you can do case review that way with the patient on the line, which provides transparency if that's an appropriate for your particular interaction. And then Zoom, consider the time limits. There are opportunities to apply for extended licensed Zoom if you have multidisciplinary clinics that could justify the need for extended licenses. I recommend trying the waiting room or Zoom rooms for your review time. So I was speaking with my husband, he's a psychiatrist. He tells me that he will just tell the patient and the learner, you know, when it's time for you, I'm going to ask one of you to, you know, go into the waiting room, and I'll just put them into the waiting room. So he said he starts with the patient first and the learner in the waiting room, gets their consent that they can have a learner with them, and then brings the learner out of the waiting room into the visit. Often will just mute his video and line while the learner is working, and then can say to the patient, I'm just going to put you in the waiting room for a moment while we review what the learner's gone over. The learner can speak with him privately and then bring all three back together. So waiting rooms can be very useful in that way. And Lynn is going to speak further about Zoom rooms after my section. And then have a backup plan, not only for your patient, but for your learner in case connections are disrupted or otherwise. This guide comes from Northern Ontario School of Medicine. I find they produce some really great guides because they have a very large number of distributed remote sites where their faculty and learners are working. So the link for that site is at the bottom, and these will be shared with you. And so I think this is an important tip. Just as when you're in face-to-face patient encounters, be they on the ward or the clinic or procedural, a small investment of time at the beginning is the most effective and efficient strategy for supervision. So just those few minutes of, okay, this is how I expect this clinical encounter to work. This is how I want you to contact me. This is what I want you to do in that session. What are your objectives? What are your EPAs? What are you working on? And it really only takes a couple minutes at the beginning of the day to set the tone and to ensure that you have a successful day together. learners are struggling. We hear that over and over in terms of pandemic, and particularly around decreased clinical opportunities. Trying to signpost to learners like what is actually still happening. We can help them to say, you know what, these clinics are going, these services are running, these procedures are happening, these ones are happening in a different way or a different site. We talked about consent, and then what to ask for virtual physical exam. In my own area, I really stress that I want them to do range of motion because you can see that on a camera, maybe rashes, although they can be distorted. Trying to figure out what's appropriate. Lynn taught me last week that she has a doll. I need to get a doll, I think, out of my daughter's room, where she will just have the doll like do different motions, like bending its knee or putting its arm up and say like, can you do this, to try and demonstrate. One of the big teaching wins I find is direct observation in virtual care, and that is a hard thing, and there is an expectation in some of our CBME assessments to do direct observation. I often find that I can, again, mute my video and mute my microphone and work on the previous patient's letter or labs while the learner is taking a history or explaining or counseling. And that way I'm not interfering with the visit, but I can really hear how they put these things forward. And then just like before, we do case reviews in person, we can do case reviews virtually, looking for probing questions. So, you know, what if this detail had changed? Would that change how you approached this problem? What was in favor? What was against this diagnosis? Those kind of questions can all happen virtually. This is a great opportunity to review their notes and to role model new behaviors of, you know, web professionalism. Great opportunity for CanMeds. We have lots of highlighted CanMeds roles when we're doing virtual care, especially in pandemic time. You know, services are decreased. How do we access care for this patient? It's going to be different. Is this test and visit really urgent? Does it justify doing this in a time where resources are limited? Some new communication skills, a coordination, you know, virtual handover, coordinating care. SUDA has emphasized lifelong learner, and just pausing on professionalism, reminding learners that they need to look professional. I have a colleague at another university who told me they were starting an ambulatory clinic and the learner was actually in the bed with the covers pulled up. So that's not appropriate website manner. Keeping on assessing, our learners still need to progress. They need feedback to improve. We want to bend that curve for them, and they still need to show competence. They can't be progressed if they don't, so we really need your help, especially when you have those opportunities for in-person supervision. This paper came out on Tuesday. It's hot off the press, and I thought it was relevant to our discussion. It's a paper about medical student virtual consultation in ambulatory care, but I felt a lot of the principles were really relevant here. So what they said is, you know, really the things that are missing in virtual care that we don't think of often are those informal times, those chats in the hallway, that just starting off clinic. So if you don't know the learner, make sure you have maybe their cell phone or a way to connect with them to introduce yourselves quickly before the clinic. For check-ins, for the before and after the visit time, to say, you know, oh, you're going to see Mrs. So-and-so, just watch out about this. Or you're going to see Mrs. So-and-so, or you just saw her, how did that go? What was going on? Are there any things that I should know about before I join the visit? So that check-in time. Signposting communication, we are all looking at a camera. It is hard to tell who's looking at whom. So rather than saying, what do you think is going on? And the patient start answering, to say to the learner, what do you think is going on? To be really clear about who you're speaking with when you're in three-way video consultation. Watching, having an eye for tech mishaps. And I want to just emphasize that last point. Be mindful of inequality that can be manifest through virtual care. Not all learners will have access to the same technology or space. They might be living in a shared accommodation with 4 roommates and may not have a private place where they can do clinical virtual care. And you might need to have a plan to mitigate that. Is there a conference room they can use? Is there a clinic room? Clarifying that they actually have a safe place where they have internet and can ensure privacy of their space. The paper that we put out this summer, a group of us, in terms of CBME during COVID, and the link is there. Some of the top points are in this infographic, and we can share that with you. But the key points are: keep doing what's working, change only what you have to, and keep the learner in mind. These are some links from our own physiatry program where they role played doing virtual care if you're looking for different opportunities, and we'll share these with you. And with that, I will hand over to Lynn.
Wonderful, thanks, Anna. I feel like I finally moved into like the adult table from the kids table. So being a pediatrician, I often don't get to interact with my adult colleagues, we like to call them. But I'm sure you just see yourselves as regular doctors. We see you as adult doctors. I get the awesome opportunity of talking about the technology. And so it's a nice overlap with what I do clinically and then what I get to do for the university in my role as Associate Dean, Educational Innovation and Academic Technologies, which is way too long a title. And so we're going to figure out many of our clinical settings involve learners, patients, and many of them, and how do we coordinate all of those logistics? And so the virtual health team at Alberta Health Services has worked with my group at the Glenrose in a multidisciplinary team to put together an incredible document that goes step by step as to how to practically make virtual visits in complexity a success. And so this document goes through and how you rotate between patients using those breakout rooms that Anna talked about to complete your assessments and interventions. So let's walk a little bit through some of those logistics. The first important piece is actually understanding the terminology. So Anna referred to the waiting room. And so if you logged in early to this Zoom webinar, you were kind of in this waiting room ready to be admitted into the main session. And so that's the waiting room. And then you come into this main meeting room. And that's where most of our interactions occur through Zoom meetings. Now there's also this extra spot called a breakout room. And a number of you are becoming more and more familiar with those. And so it's where you can separate different people into different groups. And we'll talk in just a second about the benefit of those types of breakout rooms. Essentially, how you want to think of your virtual visits is to think of one Zoom meeting ID to be equivalent to your entire clinic visit. So if you are used to doing a half-day clinic or a full-day clinic, you would now have one Zoom ID for that entire clinic. So instead of each patient having a new Zoom ID and you have to go between multiple Zoom kind of logins, you're now logging into just one session. The main meeting room becomes your staging space. And that's where your nurse or yourself or whomever is going to do that consent process that both Jonathan and Anna talked about. From there, you're going to have breakout rooms, and one is assigned per patient. We'll talk about the details of that. And then you're going to have a team room where you can actually have that team dialogue or debrief with the learner. So what does that look like to get to breakout rooms? You can see we took a screenshot yesterday, and that yellow circle at the bottom corner is that breakout room session. And so by clicking on that, you can start to have assignments of who you're going to put into a breakout room. So theoretically, we'll have a team room that we designate, and then each of our patients will also have one. So I've got one for Johnny, Anna, and Sudi. So just remember pediatrician. The beautiful part of those names that you have on each of the breakout rooms is the only person that's able to see those names is the host and the person you're moving in that you're moving that person to that particular breakout room. So Johnny is only going to see Johnny's name. When he's assigned to that room, he's going to recognize that's my name. I'm going to the right room. And then as a host, as you're moving between the different rooms, it's also good to have the patient's name, first name, last initial, or whatever works for you to be able to go through. No one else is going to be able to see those names, so the patients in the other rooms will not be seeing them. So we're still good from a privacy and security perspective. The beautiful part about creating multiple rooms is the amount of flexibility it affords. So if you think of what your clinical experience is in any given day today, in the physical environment, I know I'm popping in and out between rooms. I'm talking to the physical therapist, then I'm talking to the nurse, then I'm talking to my learner. We typically have a large team room, or there's a conversation just outside the patient room, and there's a real flow of activity that happens. And so this setup allows us to take that similar workflow that we're used to in the physical environment and transmit it into the virtual environment. The same way we don't have patients coming out of their own patient room and moving into someone else's patient room is the same within the virtual environment. So there's even additional security in that patients can't exit out of their room and enter into another room. Only the host has that ability to move from one to another. So it's just additional levels of security. And Anna mentioned about that team room. So having the ability to just tell the patient, just wait here, we're just going to go discuss a few things, gather a bit more information, and we'll be back, allows you to step into the team room environment, keeping the patient in that room. So he or she doesn't need to move back in or out, can just stay in the one room, just like the physical environment. The other real advantage to using the rooms is that you're able to have your learner in one learning environment with one patient, and you being seeing another patient in another room or working with another learner. And so you're able to move between those rooms where you're needed, which is the same thing that happens in the physical environment. And why is all of this important in terms of flexibility? It comes back to what Sudha was talking about and our need for observing our learners in the environment. And so being able to come in, keeping even my video off, so the attention continues to be on the interaction between the learner and the patient, but it gives me this valuable insight into ways that I was never able to do before in a physical environment, to watch an entire encounter, to be able to take notes, to be able to have details, to be able to send chat messages to the learner to say, oh, could you clarify a little bit further, instead of me needing to use my physical voice or interrupt that workflow. And so you're all saying, this sounds wonderful, Lynn, but how do I actually do this? And it sounds overly complicated. And I take this quote from my nurse, and she said, you need to understand the system. And hopefully I've given you a little bit of system knowledge at this point. And then practice, practice, practice ahead of time. And then you'll be just fine. And now we use this setup within our clinics seamlessly. And so at first there were a few rocky moments, but by the second and third clinics, things now move quite seamlessly throughout our clinic day. And you're saying, well, this is great, but I still need a lot more help. And I say, fear not, because the virtual health team wants to be there to help you. And so all you need to do is email them, virtualhealth.info@albertahealthservices.ca, and someone will be there to walk you through the entire process. And they'll work with your team, they'll work with your administrative staff, they'll work with your clinical staff to get this to all work in your particular environment. So they're a wonderful resource. Snap that picture with your camera, learn that, email them. They're ready to meet your needs. Additional resources are going to come from Insight through Alberta Health Services, resources for clinicians, support staff around Zoom sessions in particular, and then also additional resources for clinicians and patients with respect to virtual health. Now, I know you must come up with a number of questions as you've been digesting all of this information coming to you. And so the chat or the question and answer is open. You have an opportunity to vote up different questions if you share those. And so we're looking forward to having a bit of dialogue in the remaining 15 minutes together.
Thank you, everybody. So I'll just get everyone to come on video now. And all the links, there's been a lot of links that have been provided. So they're in the chat box, but also, as usual, we'll be posting this presentation. And then at the end, we'll also provide all the links that were presented. So thanks, everybody. I think the first question was around some of the I guess, challenges we've had within AHS facilities. Lynn, you might know about this, and I'll give this over to you or Jonathan after you've had a chance. Is as you may or may not know, a lot of the computers at the K Clinic, for example, don't have video. In some cases, they're very limited in terms of audio. So, trying to work back and forth, being in clinic, seeing some real patients and then virtual patients. Do you have any suggestions of how you've overcome those challenges? Are there any updates in terms of, what's happening with regards to equipment in the clinics? Can you help with any of those questions?
For sure. So one of the pieces that we do is with laptops. And so we physically will bring a laptop into the patient room if we're doing a blended model. So if I have in-person patients, I assign them to a room. And then we physically take a laptop that has the video connection, the video camera embedded within the screen functionality, and put the actual laptop in the patient room. For us, it's just that mental way of physically moving from room to room and recognizing where a patient is at. Connectivity, the video sort of pieces, all of those are real issues. So the use of laptops has been really effective for us. But then finding an actual space. So I know one of our speech language pathologists was in a back closet, it seemed. So again, not the most professional website manner, but that was the only space she could find in the building that was private and confidential with her laptop. I think as clinicians, I do some of my virtual clinics from my dining room table right here. And so again, I'm able to zoom in, and with the COVID wave number 2, quickly approaching, we're going to be seeing a lot more movement back into our home environments, I think, again.
Jonathan, did you want to add to that in terms of equipment that you're aware of in facilities?
So I guess the first thing I would go back to my principles of asking the question. I recognize that having video, enhances rapport, but at least in cardiology, most of my patients say, I don't want to bother with that, just phone me. Because I've used video on a few occasions, like for example, the patient on warfarin who said that his toes were bruising. So I said, put your video on so I can take a look to see if it's the real deal, and it was just some traumatic thing, right? But notwithstanding that, if you need video and absolutely need video, what Lynn says is true. The laptop has the strongest antenna for Wi-Fi. The iPad is second, and then the phone is third. But certainly we can, and especially if your patient's on My AHS Connect, you can actually launch the video visit in Connect Care and hand it over to either Haiku or Canto. I've only done that once, because in cardiology, there's very little that I can do visually. Now, it might be different with Anna, and you may have more experience of.
Yeah, in our setting, both my residents and myself, when we're actually in clinic rather than doing the clinic from home, as Lynn said, we bring a laptop, and we do have laptops available for residents should they need them, but I agree, it does make it a lot easier. I noticed that Joanne has asked about, do you need a second screen? And it's easier. I actually preface the visit to my patient saying, I'm working on 2 screens. I might not be making correct eye contact, and I just warn you in advance. And it's nothing to do with me not interested in what you're saying. I'm just trying to juggle what we're doing here. And I think if you just call it out and say it to your patient, it doesn't seem as weird as you constantly looking like this as you're talking to them. But trying to figure it out.
And I think the caveat to that is the Alberta Health Services principle is whatever the most minimal technology is that you're able to use for that visit, then use it. So similar to Anna, I do physical medicine and rehabilitation. So part of that piece is the physical examination, movement, etc. Or so I need to see children in their play. And so I need to visually observe that. Or I'm giving a new diagnosis and I want to see how that's landing, and I need to read the nonverbals from a patient. And so that happens to be what my clinical practice is day in, day out. But you're right, for Jonathan, when he's talking about lab results or giving updates, he doesn't need to physically see the patient the same way that maybe Anna and I do.
One other thing, Norman, if I could interject something too. Like, for example, I have my colleagues and my patients are very community-based as compared to institution based. And so when we first started this, it became very clear what kinds of technologies we had, bandwidths of different platforms and so on. So that's a consideration too. What really helped, actually, I have a lot of patients who are rural. Like I see a patient on a virtual platform, in fact, and he works in Kitimat, BC, and he's been seeing me regularly. But if the bandwidth is not great, the internet is not great out there, they actually have a health team. So for example, I use my team a lot. Like I will call the nurse and say, do you know, you're observing him, what do you see? And so we can do some by video, but if it's just not working, we'll pick up the phone. And if you do have a health team somewhere else who you can collaborate with, they can do some exam on your behalf.
Thanks, Sudha. I think that addresses one of the questions that's in the question mark box, which is, we know, and with our virtual hospital, we found this very commonly, is that with our socially disadvantaged population, or, with some of our elderly population, as Jonathan has alluded to, not only often they won't have access to video, audio, and, a computer access, but even sometimes cell phones can be a bit of a challenge. So I think you've covered that off. Are you aware of any sort of mitigating strategies for those patients, given that, AHS has identified that we're only supposed to be seeing, a lower percentage of patients in person? I'll put it out to Sudha first, and then Lynn.
Yeah, no, I think that's a good point, Norman. Yeah, no, I think that, like for example, I mean, I rely quite heavily, just based on the different variations that there are, especially in the community. It's very hard to standardize across the board the kind of technologies that we've got, and the abilities to make that across the board even. So it does require some creativity. It does require, who are your team members, and in family medicine, and also I know at the Department of Medicine, we're always thinking about, who are our team members and who helps us take care of patients. And I think that's a really important consideration to say, well, there is this challenge. How might I get around it? And there are people to help us do that.
What we have to realize is that virtual health isn't new. And so we used to call it telehealth, and it's now sort of been rebranded. And so there are health units throughout the province. So we recognize that we serve the largest geographical catchment area in North America. And so those health units are situated throughout, and most patients have access, even on reserves, to that local health unit. So oftentimes I'll send the patient to that health unit to use their secured video system, the telehealth system, and link in through that. And so while that may not be the best solution during a pandemic, when isolation is more of an issue, as we continue to move this forward, I believe that will help address the disparity by just a quick 10 or 30-minute drive to their local health unit versus an 8 or 18-hour commute to our health unit or the hospital.
Agreed. Jonathan, could I ask you to comment on security? I know you touched on it a little bit at the beginning of your talk, but there was a question about AHS and Zoom bombing and all the rest of it. So I'll just ask you to finish that off, please.
So, I mean, if you go into the Zoom settings, there's a lot of advanced settings and security features. And without going into too much detail in the interest of time, a lot of those features are enabled and locked on the AHS platform. And therefore, we don't recommend conducting clinical care using the non-AHS version of Zoom for many reasons. But things like allow join before host, that sort of thing, or the secure chat or the virtual background, or must have, there's a feature like you must join with a password, stuff like that people in those those social Zoom bombing situations didn't have them. They allowed everybody to join without a password. So I could forward you the link and you could have joined, right? So those are some of the things that do not exist when you send out an invite using the AHS Zoom with the features locked for So you have to be careful. And within Connect Care, especially, that's why we're actually making a pitch to say, for those of you who are seeing patients in Connect Care, for those patients who are inclined, encourage them to sign up with MAIDI, which is my Alberta Digital ID, and get the access to AHS, my AHS Connect, which will then allow them even to request down the road their own appointments online.
Thanks, Jonathan. I think there's some questions around, how some of you have gone about developing your virtual clinics. Have you had administrators sort of that have helped you, or clinic staff that have set it up, or are you doing it on your own? Or you mentioned you're doing it from your dining room table, Lynn. Just from all of you, maybe how are you actually doing the setup?
So the virtual health team has been wonderful in coordinating our whole team, right from the central intake group that's booking the appointment, to the nurse that's doing follow-up and sort of administering that, to the clinic coordinator who's doing all those pieces. And so it is definitely not falling on me, the administrator or the physician on the team, to pull that together, because let's face it, that would be a disaster. And so even though I am the one here in my location, I click on that link and the rest of the team really just does each of their little parts, and it's working well. So that's been my experience.
Anna?
Yeah, I just kind of wanted to outline a quick evolution of how this has happened and different options that I've seen. When it first started, I would create the links because my admin didn't have host access, and then that AHS has remedied and allowed our administrators to have that access. So then she learned how to create the links, and she will create the links and then send me a calendar invite with just the patient's initials and the Zoom link and the appointment times, so that I can just click those out of my calendar. However, my husband, I mentioned, is a psychiatrist doing inner city psychiatrist, so he deals with the inequity issues, and I can speak to those later. But one thing he has found, they don't have a lot of admin support at all. So he has shifted to creating a half-day clinic, and then the admin just sends the clinic meeting ID and password to all of the patients. It's the same, so it doesn't have to create each appointment, and then uses the waiting room to just move those patients in and out. The patients are told you'll be in the virtual waiting room until the doctor's ready to see you. And that way he's not having to create multiple time slot appointments. So he just creates a half-day clinic, and then those are communicated, and then he just admits and unadmits the patients in and out of those waiting rooms. So there's many ways to do this to try and minimize the burden of this workflow using the security features within the AHS Zoom. As far as
did you want to... Sorry.
As far as disparity goes, I think the solutions that have been presented, so using your team, if you have a team, using the telehealth centers is a huge thing that they do in that team. They do inner city psychosis, and so those patients really don't have consistent access to cell phones or computers. And so their outreach workers will sometimes go out to them. They use the telehealth features extensively. And then sometimes you just have to bring people in. We all have to recognize there are limitations to virtual care. It is not suitable for all settings. And so just, we're trying our best to minimize patient contact, but being thoughtful about when we use this and when we don't.
Narman, I can be really brief. In our academic centers, training centers, we do have a position called quality coordinator, and they all work together among the different academic clinics. They've been really wonderful in helping us to coordinate virtual care, and so that it's standardized across at least all of our academic centers, and so the learners who come through there have a very similar experience. We don't have one for the broader community or rural, and that's something that we're certainly working on. But all of our rural and community clinics know that they can contact the department, and one of our quality coordinators will help them. And I agree with Anna and Lynn. This is something that you do need support for. So there is support. Some of the resources are available that we've provided to you. Reach out to them. They might be able to provide help or support or some suggestion that you haven't thought of yet. So they're very valuable to reach out to.
Thank you. So we are coming to an end. I know there was a question around college requirements and things. I will point out to people, there is a link within the Department of Medicine homepage. If you go into the COVID site where we've got our COVID information, there's actually a link to virtual care and what the CPSA updated guidelines are around virtual care. But we'll include that link as well in the slides that are eventually prepared. So on behalf of the department, I want to sincerely thank the four of you. That was outstanding, really, really helpful. I think we're still learning, lots to learn, but you guys are clearly leading the way. And so I hope it's okay if individuals reach out to you if they have questions. And I sincerely appreciate your time. Just a couple of things. Next week, actually, we are our rounds very timely, just the day before Wave 2 launch. We are going to be presenting a Connect Care topic on how to access data and sort of moving forward with the next phase of Connect Care for those that were in Wave 1 in terms of accessing data. So hopefully you'll be able to stay tuned. And then the last thing is please, please, please get your flu shot. The flu carts are available at all the acute care hospitals from 7 in the morning till 10 o'clock at night. So whichever hospital you're at, it's either in the central location or there's carts going around the acute care units. So please get your flu shot. Once again, thank you, everybody. Thank you to the four of you, and thank you all for all the hard work you're doing. Take care and stay safe. Bye.
Thanks. Nice being here. Bye.
Take care, everyone.